Okay, thank you, Alejandra, and thank you everyone for being here. So today I'm going to talk about dignity and preserving the dignity safely in the home. I'm the owner of Aaron Home Care in San Diego. So a little bit about me. I spent 20 years working with seniors and adults with disabilities. I've owned my company in San Diego for 9 years, almost 10. And most of all, I'm a husband, a father, and a human being. So I have a background in working with adults with disabilities, and much of my philosophy of care comes from this world. A lot of what I was taught. Back in the 70s, 80s, there was the era of deinstitutionalization, and they let the people, the adults with disabilities, back out into the communities and into group homes, and that's where I worked. And they were taught a lot about the concept of normalization, which we're focusing more just kind of rethinking how we work with people with disabilities and focusing more on our similarities than our differences and more on empowering them. And some of that was person first language, saying adults with disabilities is a form of respect instead of disabled person. And language really does matter. You'll notice this is me with someone that I took up to Atlantic City. We went out, we went on trips. When I was young, I was dressed in casual clothes. That's something we were taught to not trigger to everyone in the outside world that we were nurses or hired help. You know, it was just trying to help them blend into the community. And the focus was really on letting residents do for themselves what they can. And so dignity and respect was a large part of that, and respecting what they could do and not just focusing on what they couldn't do. So this is my family, which has also influenced me a lot. This is my wife, Pam, who was a teacher for 10 years and then became a parenting educator, and my son, Kevin, our son Kevin. And the philosophy that Pam really taught with parenting was the same. It's that the children are more cooperative with treating with dignity and respect. You instill a sense of self-esteem and self-worth when you are treating people with dignity and respect. Next. And that comes to people of all ages. It's just the basic truth that people of all ages feel and do better when treated with dignity and respect. And this is Pam's grandfather. He was a jazz pianist. He'd play for us at Christmas. So when I founded my company, that's really one of the core values that I brought to it is, and from the disability world, it was really about giving them a good quality of life. I mean, these people were disabled their entire life. So it was really, how can we enhance this quality of life, not focus on that? And dignity is a large part of it. I believe in treating everyone with dignity. That's something we all want. Next. So what is dignity? Dignity is the right of a person to be valued and respected. It's a sense of self, self-esteem, self-worth, self-respect. So this talk mostly is formed around dignity of risk. And this was huge in the disabilities field. And I don't hear this much since I started working with the elderly for 10 years. I still don't hear it much. And I think it correlates exactly. We were talking about working with people with diminished mental capacity, yet dignity of risk was very important, and it is the right to choose what you do and how you want to live, despite the fact that those lifestyle choices may come with risk. So examples for me would be the right to watch TV instead of going for a run, not sticking to my physical, plan, my physical fitness plan that I'm just going to eat cookies today and watch TV because I don't feel like it. The right to play rugby, which is something that I love to play rugby, and obviously, causes a few broken bones along the way. It did impact, physically. The right to start my own business, knowing it was a financial risk. It wasn't really a sure thing. It put, you know, put me out on a limb, but that was my right to take that risk. Next. So the examples for our loved ones are the right to eat cookies when you're diabetic, or the right to continue living on the second floor when you are a fall risk, the right not to take medications. These are very real questions that come up for all of us. Next. So right now you're probably thinking, well, wait, this is my job is to protect them. I can't just let them eat cookies if they're diabetic. I can't, you know, this is where you're coming from a role of protection. And this is called duty of care. So for family caregivers, it means that you are obligated to make sure no harm comes to your loved one. Next. So, however, you can deliver care that has excellent outcomes to a person's physical health, but if your loved one hasn't been able to make choices for themselves or they haven't been assisted in doing the activities of daily living, you could damage a person psychologically by undermining their dignity. Next. So people often see these two in contrast, dignity of risk and duty of care. So duty of care is the physical safety where we're saying, no cookies ever. I'm responsible for you now. And we're following this very strict diet, even though you may not be. You go home and not be. And then dignity of risk, which is someone's psychological well-being and their sense of self-worth. So the scale is to show it's a balance. That's what it is. Next. And this is another way to show it's not in conflict with each other. What we're really trying to do is find that sweet spot where you're not too much on one side, where they interact and we can give someone dignity safely. Next. So if you go too far to one side, dignity of risk, if you say, oh yeah, go for a walk and you know that they'll get lost, or go, really just not letting them do whatever, you can get into neglect, irresponsibility. No one is saying that. Obviously, that's a lower quality of life. But at the same time, we tend to often, as caregivers, go too far on the side of duty of care, and we overprotect and we smother and begin to even treat them like children maybe. And that's a lower quality of life too. I just want you to recognize and be conscious of the fact that you can go too far on that side, and we still really want to maintain the person's sense of self-worth and self-esteem. So it's been proven that overprotection of people with disabilities causes low self-esteem and underachievement because of lowered expectations that come with overprotection. And they found in elderly people, overprotection can result in learned dependency and a decreased ability for self-care. So at the core of it, I think it all comes down to choice and control. As you age and you lose your driving and you lose a lot of control and independence in your life. So the ability to retain control over choices in everyday life boosts one's sense of well-being and is protective against depression. Next. So the key to be presenting choices first is this, to be aware of it, to just have it in your mind that you're looking for places that you can give choices, not always focused on what someone can't do, but let's focus on what they can do and where can we give choices and implement this into the day. The key is adjust depending on the stage. I'll talk about it a little bit further on the different stages of dementia because it is a little different and obviously safety is at play. To limit choices so you're not overwhelming the person or allow for choices that aren't feasible. And be creative and how to accommodate for choices may likely be picked. And then to be creative, there's an example such as if someone picks the same sweater out every day, what you can do, and you're thinking, oh, I want to keep them clean, not wearing the same clothes every day, but they're telling you they like that, maybe the feel, the color. You can buy several of those same sweaters so that you can wash it and keep it clean, but they're still having the choice to pick the same sweater every day if that's what they like to wear. And that's, you know, you're really balancing, you know, your need to wash the clothes with just their self-worth of picking out what clothes they want. Next. So, as caregivers, we often fall into the pattern of doing things for the person rather than with them. But we really want to foster that sense of independence by giving choices through the day. And we're looking for things of what to wear, what to eat, choice of activities, times to wake up and go to bed. Those are all important choices we all make for ourselves. And it's clear that these choices really help someone maintain a sense of control and independence over their own life, which can help decrease the frustration, which ties in very well with the triggering of behaviors that Alejandra talked to. Is that can be a trigger to behavior when you're feeling you have no control in your life and everyone's making decisions for you and you wanted to wear, you know, that sweater. um, so it can make the caregiving process easier and improve the quality of life for the individual and the caregiver. So I broke it up into the different stages and some how to preserve dignity through choices in the early stages. Next. So the early stages are really an opportunity. If you were diagnosed early, your loved one was diagnosed early, it's great because you can go over important life topics now if you haven't already done so. So now they really can speak up and give some control in their life because you can talk about the reality of what's going to happen and say go over those. Okay, what do you want me to do in this case? If this scenario comes up, how do you want me to handle it? And get their input from the beginning. How do they feel about eating food that are against the doctor's recommendations or using stairs if it's a fall risk? You can talk about the long-term living plan. Would they like to go into assisted living, memory care, or stay home with caregivers? Driving, that's a big one to talk about. If you talk about when should I stop driving? When is it okay for me to take away your keys? Um, and then end of life decisions. What are their values and preferences regarding medical and life care? Filling out that advance directive, the pulse, the DNR. Um, a lot of this, the more you can go over this, also alleviates a lot of guilt on your part because there are a million decisions that go on that it's just not black and white and they're different for each person. So the more input you have, the better. But I also want to stress if you're past that part to not feel bad, I mean, really you're trying to just think what they would think. You could go through these questions and probably answer some of these yourself for your loved one that you know well. And really, you want to integrate their philosophy into how you're helping care for them. Next. So build a team and reinforce the fact that your loved one is at the center of the team. So all of a sudden, all these people have input in their life: physical therapists, caregivers, primary care physician, extended family, professional caregivers. So that's another way that the care receiver, that, you know, the person with dementia, can feel like all these people are in my life telling me what to do. It's very important to make sure that they remember, and is pointed out, that they're the head of the team. Everyone's there to support them. At the same time, it's extremely important, you as a caregiver, to build your own team, because as these difficult questions come up and you are balancing dignity of risk and safety and what should I do, it's great for you to have a team to bounce things off of, a team that, you know, can help support you in your decisions, difficult decisions. Next. So in the early stages, just this is the stage where you're most likely to be overprotective. You really want to reinforce and let the loved one do as much as they can while they still can. And to avoid pet names, to not call them baby, sweetie, if you haven't done so, obviously. Um, but that's something we talk about in professional caregiving, just to not patronize the person just because they now have a disability or dementia. Now, how to preserve dignity through choices in the middle stages. Next. So, as dementia progresses, our loved ones may need more support to help them make their own decisions. And that's key, not need more people to make decisions for them. It's more support to make their own decisions. So, you want to really set them up for success, really think where they're coming from and pay attention towards the time of the day. The middle stage, I think, is a time people can get dismissive of their loved one with dementia because they may have made a poor choice here and then they think, oh, they can't make any choices, but it's kind of a muddy time. And you want to really make sure that you're giving them the best chance to really be a part of the conversation as possible and make sure they're hearing you. Are they wearing their glasses? Is the time of day? Are they tired out from the time of day? You know, talk to them at eye level. It's good. That's a big one, especially people in wheelchairs. I always squat down or sit down. So I'm talking to someone at eye level, and that's big for dignity and respect, and always having people looking up to people and people looking down at you. Um, and really listen to them. And like how Alejandra said, you're listening for the gist also of what they're saying, not necessarily every word. Next. So then you revisit, this is where you revisit some of these exercises. Did she want you to support her living on the second floor? Did she say, I want to have my independence at all costs, you know, even if I fall and break a leg? Or she said, no, please make me come down. I don't want to break a leg. People, you know, we care for a wide variety of people, and I'm big in trying to understand them and respect their different decisions in each house that we go into and how they want to live their life, because to me that's what it's about. Quality of life is so important. So people feel differently on these. Did they want you to grind their medications and hide them in applesauce so that they were still taking their medications? Or if they say, hey, I want to stop taking my medications, then you know, are you respect that fact. That's a very difficult one. That's a good one to talk about before you go there. And it's also good to have your team to help make those decisions, you know, but really use their philosophy from these questions to help guide you. Next. So these are ways to encourage participation with dressing. You can hang, you know, take a lot of all the clothes out of the closet so there's not so much that's overwhelming, and hang a few sets of complete outfits together on the hanger, complete hanger. You know, you want to make it not a frustrating experience, but an empowering experience. So you want to limit the overwhelming choices. You know, you pull out two options. Would you like to wear this or this? Sometimes, you know, even if they're not able to articulate, they're just pointing or looking at that one, then you know which ones. Allow them to physically dress them as long as they can. You know, just keep in mind they experience memory difficulties, slow thinking, poor reasoning, problem solving, shortened attention span. It often requires an extra degree of supervision, time, and patience. And that's really a lot with the slow thinking. I see a lot of it is just on delay. So give the person a minute to really process what you're saying. Take your time. There's no rush. Signage can help with decision making. So you can say, choose one pant, you know, choose one shirt, um, choose one pair of socks. This is another way to really help guide. Keep in mind the vision. The vision is, it, you know, goes for all elderly people or most. So the contrast is very important. Next. Same with foods. You can make picture cards of favorite foods. Present available choices, label section of the pantry for clues. There could be a designated snack section for them to choose from. I went into one home recently and the husband was telling me, oh, she keeps sticking food down her shirt, and she was getting rashes from all this food that was accumulating down her shirt. And, we thought, well, I said, maybe she no longer has access to food anymore. She just wants to have the independence of having food whenever she wants. So in her wheelchair, if you can just put a little place or a purse where she can hold a bag and have food and put healthy snacks in it, or unhealthy, if that's what you want, but have access to food, she'll stop putting it down her shirt. So next. And then make additional provisions for dignity of risk. Walking, if they're a wander risk, add a GPS tracker on the phone. The register with the sheriff's program is great. Find a walking group. Finance is a big one. It's very hard to go from one day managing all of your finances to the next day having zero money, no access to any money. You have to go through someone for permission. So providing a small account for the medium where you're limiting financial risks, they're not going to give away all their money or spend all their money, but you still have access to a certain amount of money that so they can go out and buy something if they wanted. And that's a real important one. It goes very extreme. Um, so also there was a client I went to recently where I had a call from a caregiver and said, "Oh, the client's going to fall out of his wheelchair. He's insisting that he had Parkinson's. He's insisting on raking the leaves, and I'm scared." And she was kind of fighting with him because she didn't want him to fall on her watch. At the same time, the sister was taking care of him, and she said, "Oh, you can do whatever you want." So I went over there to kind of see for myself what was going on and work through it. And he was, for Parkinson's, it was pretty impressive how much yard work he was doing. But that's what he loved. That's what he's always done. And his sister and him were fine with getting a few scrapes along the way. So just really had to teach the caregiver she's not going to get in trouble. If something does happen, we'll really try to make it as safe as possible, but we're not going to let him not rake leaves because we're scared he's going to fall out of his wheelchair. He was going at it. It was great exercise and he enjoyed it. So that just another example. But as we get to the late stages, so how to preserve dignity in the late stages. Next. So the late stages, you're listening for the hidden meaning, may not be able to properly express themselves or at all. So you're really looking in for nonverbal cues. You don't really say, "Oh, they're hallucinating." Just realize their experience is different than one of ours, but not to invalidate that they see things that we don't see. Uh, how will the approach the doctor is suggesting affect your relatives' quality of life? Going back to those questions of, how aggressive did they want the medical treatment at the end? Will it make a difference in comfort and well-being? You're really looking for comfort and well-being. Next. And then another way is for you to really help them keep up their good hygiene, to brush the hair and teeth, regular baths, clean clothes and bedding. So if a neighbor comes over, they don't look at the person all disheveled. I mean, really, the way they look really will, convey a sense of dignity, a sense of respect that will come from the others. So make sure they're getting shaves and haircuts. Still put your choice, trying to ask, "Do you want to wear this outfit today?" They may not be able to engage, but really try to, learn their nonverbal cues. And if they're bedbound towards the end, you don't want to limit their clothing just to hospital gowns. Sometimes it can be difficult and painful moving people around. You can take some of their clothes and just cut up the back and make them some shirts so you can flip right over, but so that they're still wearing regular clothes. When people come visit, they're seeing them in regular clothes. That's really a big one of normalization. And just revisit their wishes for their end of life care. Next. So dignity of risk, is it worth it? So I'm going to show a short video now, and we're going to skip a little bit, so we'll just bring you in. So, but Raymond is the person with dementia that has a caregiver, and he wants to spend $50 on lottery tickets, and the caregiver was really against it. That's a waste of money. You're not going to win the lottery. Okay, go ahead. And this is what happens. I can't hear it. Yeah. Hold on.
Well, Raymond, it's been a pleasure as always. Have a nice weekend, yeah?
The lottery.
Well, seeing as you asked so nicely, how can I possibly refuse? Haven't you got anything smaller?
All of it.
Raymond, you only put £2 a week on the lotto.
I want 50 lucky dips.
£50 is a lot of money.
I know how much £50 is.
You can't afford it.
It's my money.
Yeah, but you have to buy food, you have to pay the bills.
It's my money.
I know, it's your money, Raymond. But have a think about this for a minute, yeah? Well, what happens if you lose all of it?
What happens if I win, eh? Yeah. I would be able to afford proper servants then, not pushy girls like you telling me what to do all the time.
I am not a pushy girl, and I'm certainly not your servant. This is madness.
I am not mad. I'm old.
I didn't mean that. Look, I just mean that I've got a responsibility to make sure you're okay.
To tell me what to do, you mean?
All right. You obviously know your own mind. If you think you can afford it.
I can afford it.
All right. Do what you like. I'm logging this in the book.
Oh, yeah.
I'm not taking responsibility for how you waste your money, Raymond. Spend it how you like.
I will.
Let me tell you this for free. Chucking your money away like this won't make you happy. Whatever.
And the first ball tonight is number 4, one of the most frequently selected balls on the Saturday Lotto draw. Number 4.
4. 4. Yeah. At 4. Yay.
27.
27, yeah. There's one. Yeah. And there. Oh, hey, hey. Yeah, yep. Whoa, another one. There.
12.
12. Yeah, wait. Slow down. Will you? 4, 22nd, 12. Yeah, go.
So tonight's final lotto number is 13. That's 13. 13. Good luck, everybody.
Well, that was a waste of money.
13. Come in, number 13. Your time is up. 13, my lucky number. Oh, 13. Yes, 13.
So that's just a perfect example of having two opposing views of, duty of care financially versus the dignity of risk, and how he really was paying for the experience of it. He wasn't trying to win, but next slide. But it is worth it. It's worth it. So And that's it for today. I just thank you for coming, and I challenge you to really look for your loved one's abilities and how you can help them make choices instead of focusing always on the disabilities. Um, I also have product recommendations. They're not all for dementia, but mobility. I do a lot of talks on mobility as well. So, does anyone have any questions?
Yeah, I just wanted to share, Erin, that this whole concept, I've not heard of it before. This whole dignity of risk versus dignity of care, that compromise, and I think it's fascinating. I really appreciated hearing it. My mother-in-law is, sometimes seems to have mild cognitive impairment, and she's got diabetes and high blood pressure, blah blah blah. She's 84, but this whole concept is fabulous. I really appreciate it. I mean, you kind of have to pick and choose.
Yeah.
Where what you can let go of, but it's fabulous.
Oh, thank you. Thank you. Yeah, no, that's why I really like to give this talk, is because it was so big. I mean, it's kind of everyday knowledge, I feel like, in the working in disabilities. And when I started working with elderly, never hear it. Yeah, it hasn't really come into that space, and it fits. It just fits so perfectly. So
Exactly.
I would like people to think about it more. So.
Erin, if you could also add your email or your agency's email in the chat. I did receive a request for your email information.
Excellent. Thank you. Yes, I'll do that.
I'm not sure about this question. Do you come, maybe I'm not reading it right. Do you come into the HOE?
Oh, home. Yeah.
Oh, home. Okay. For several hours a day.
Yes. So we have caregivers that come in anywhere from 4 hours to around the clock. It's really based on individual needs. So I come out and we named it Aaron because we're trying to stay, small. Where I come out, you'll know me. I come to the home and really do the evaluation, and then bring the caregivers in from anywhere from 4 hours to, a couple times a week, to we care for some people, around the clock.
Well, I think this was wonderful, and I think more people need to hear this message.
Thank you.